thank you, Murad, for the invitation, and thanks to the organizing committee. It's a pleasure to present, and it would be even better to be in Cairo, but traveling still is often. I would like to present you with of our setup in our hybrid room, including some of the newer image guidance tools. These are my disclosures, and I am related to the Philips company as a consultant, so I am biased regarding the type of some information about our center. We are in the north of Germany. We're the second largest city in Germany, and our university medical center includes more than 1,700. We have integrated a cardiac center, or the heart and vascular center. Vascular medicine, where I serve, is a part of. Medical imaging has gone through a lot of development stages, and this is what X-ray looked like about 100 years ago, and this was associated with significant health damage to the practitioners and probably to the patients. But that the use of imaging and fluoroscopy equipment can be damaging still is valid today, and some early innovators in that field like Ted Dietrich has suffered probably significant damage from using too much of radiation. But to look at the positive sides, aortic interventions have gone through an amazing development, especially with the imaging, comparing old images from the early interventions with what we do today, where we can use very complex endografts. This is probably just possible due to modern imaging technology, both in the preoperative planning and intraoperative usage. The technologies have developed since the invention of X-ray, but mainly in the past 20 years, and everything that you see here are technical developments in the use of fluoroscopy and DSA, and I would like to show you some of these developments, all in the vascular field. What is amazing is that most of developments of that X-ray has been in the vascular. What we have in use in Hamburg is actually the Allura Clarity, which is a modern fixed imaging system. We use Vessel Navigator as a CT fusion, and we use FORS technology, which I would like to introduce you to at the end of the presentation. Our hybrid room in Hamburg, which this is an image of, has been used for a lot of complex aortic endografting, and this is just the development up to 2015. Currently, we do around 350 cases of aortic repair, of which around 180 are complex. What has changed over the years, moving from a mobile C-arm to a fixed imaging system? Mainly, on the advantage side, there's a better image quality and a larger detector size to be used. Furthermore, we have better radiation protection with all the shielding, and the workflow is easier in a hybrid room. But what we have to be aware of when we install a fixed imaging system is that these machines are so powerful that the radiation exposure, both for patient as for the user, can be much higher than in an old mobile fixed C-arm situation. This has been proven and shown in many studies where it's been shown that the dose of radiation used in fixed imaging rooms, so-called hybrid rooms, is much higher than with the mobile C-arm. In our center, we have looked at the impact of the position of the operator on the radiation exposure, and this is was our standard setup a few years ago in BIVAR, where the operator was at the patient's head, while in FEVAR it's at the groin on the patient's right side. In this study, we looked at the real-time dose monitoring using the dose-aware system, and what we've seen is that there's a significant difference in radiation exposure to the operators. where you see the first operator receiving significantly more radiation, and especially when being in an unfortunate position at the head of the patient where he cannot use all the shielding provided when standing in the standard position at the patient's groin. In this same study, we also looked at the difference between the older imaging system of 𝗍𝗏𝗋𝗋 from Philips to the newer imaging system, which includes a lot of new software tools like an automated image fusion, as well as an automated pixel shift within the system. And what we could show is that there was a significant reduction in radiation with the newer system, which of course is not a surprise, but which should motivate us not to use our old systems for a too long time. Recently, there has been the introduction allow us to keep our place in the right groin position at the patient. We could show that the dose area product with this transfemoral access for branched endografting leads to an even further reduction in the radiation dose. So also our surgical technique determines how much radiation we are exposed to. An important step, as we discussed, was the availability of CT fusion, where preoperative CT images are overlaid over our actual fluoroscopy images. There are different ways how the preoperative imaging can be registered to the fluoroscopy images. We usually use 2D, 3D registration, only with 2 fluoroscopy images. But we can also use cone beam CT, which is much more exact, but also requires more X-ray. This is just an example, and you can easily understand how much this technology, where you can overlay the orifices of the target vessel on the fluoroscopy image, can help us in the exact placement of the complex endograft, which here is a 4-fenestrated endograft. The use of CT fusion, and this is shown in a number of different studies, not only is a more convenient tool to use and motivates the whole staff in the operating room, but also can lead to a significant reduction in radiation dose and fluoroscopy time, as well as contrast agent. As a last part of this procedure, this talk, I would like to introduce you to the FORS technology and have a short edited live case at the end of it as well. This technology, I believe, is the modern way of doing low-dose complex repairs using guide wires and catheters that have inbuilt a fiber which is able to visualize the whole length of the used devices, generating an image of our catheters and wires that looks like this without using any radiation. So you see here how we play with the wire, and you can see how well in real time the shape of the wire is displayed in a 3-dimensional animated ways with more beautiful colors than the black and white that we're used to see. It is as fast as X-ray. Actually, it's a little bit faster. It is slowed down in the imaging to make the view or the experience be very similar to what we do in X-ray. The setup of this system is very similar to a standard system. It's just an add-on of a hardware unit at the back side of the monitor, and there's a docking base where the catheters are attached to. This is important because these fibers in the catheters and wires have to be attached to the hardware system. Otherwise, the system would not be able to reconstruct the shapes. Here you see how this looks in a real case. You see a 4-fenestrated device, and in blue the catheter, and in yellow the wire. And you see, for instance, you can see that the white tip at the end of the wire gives you a very good illustration of the 3-dimensional position of it. What's also important is that you can use biplanar views, so you can have different kind of angles in different panels on your image. This is especially useful in cases where you want to access ventral branches like the SMA here, because you don't even have to be a background image, and you can only operate this one from an AP view. It's also possible, after you generate an angiography through the catheter, to use that then as an overlay in order to catheterize the same vessel. How well the 3D visualization improves your understanding of the three-dimensional structures you're actually working with is this example, where you see that we have a somewhat twisted situation with our catheter. And you can see that with the fusion, you easily understand in what way the devices are twisted and what kind of rotation you have to use to detwist it. Because if you go in the wrong direction, your catheter and wire may just flip out of your target vessel. Here's a short case to illustrate that technology again. It's an 80-year-old patient with a previous tube graft repair and a 6.3 centimeter 𝗘𝗴𝗆𝗃 type 4 aneurysm. This patient was planned for a 4-branched custom-made device, as you see here. And you can see here how the catheters and the wires are connected to the FORS system. It requires a few minutes to first register the CT fusion, the overlay of the preoperative CT images of the same patient with the marked target vessels. And after that, we need also 2 fluoroscopy images to register the device, the FORS wire, and the FORS catheter to the system, so that the system exactly knows the position. And you can see that also the length of the catheter and wire are adjusted in order to get an exact visualization. Then, as usual, the device is fluoroed and introduced using CT fusion. You can see the markers of the branches, and I know that you use T-branch in Egypt now frequently. Here you see the placement, also using the markers, the circular markers for target vessels. In this image, here you see the hypogastric arteries, so that the iliac component can be displaced safely without obstructing it. And in this procedure, we usually leave the contralateral side open, because if this procedure turns out to be complex, then we can still leave it open for temporary perfusion to lower the risk of spinal cord ischemia. Here you see how we use a steerable sheath with a stabilization wire, which is a 14 wire. And here you see the FORS equipment, which is a catheter and a wire. And I'm actually here trying to catheterize the celiac artery branch. And you can imagine how this biplanar visualization helps you a lot in understanding and seeing where you are in the three-dimensional space which you're working in. This is catheter and wire already in place in the splenic artery, as you can see. The wires and the catheters have not exactly the same qualities yet of our standard catheters, but in most cases we can use them very well. Large parts of the procedure are still done with standard fluoroscopy. Here you see the bridging stent introduced in the celiac artery and then inflated in order to connect the branch to the target vessel, and the selective angiography at the end of this target vessel. In this case, the FORS catheter didn't work very well, so you see that we use only the wire in connection with the standard catheter. So here you don't see the catheter, but actually the catheter changes the shape of the wire so that you can still have a good idea where the catheter is. This is, of course, the right renal artery, and you see again standard procedure: bridging stent deployment, balloon inflation, selective angiography of the target vessel, and then in the end, a final angiography or selective angiography and a final angiography in order to make sure that all the target vessels are perfused and you have no major endoleak. So in this case, what is remarkable is that the fluoroscopy part of this procedure, due to the use of FORS technology, is significantly reduced. Usually this would be as high as the dose from DSA. We do collect all these cases, as this is a fairly new technology, with our partners in the FORS Clinical Learn Registry. We look very much forward to this technology becoming even better to be used with standard catheters, as there is a so-called 3D hub that can be connected to any catheter, so that we can visualize any catheter by only using the FORS wire. And to conclude, radiation dose reduction is a central task in my mind in future imaging innovation, especially for the users, which is you. Fixed imaging systems in hybrid rooms have significant advantages, but we have to be aware that this tool is more dangerous than the mobile C-arm. And modern imaging acquisition systems, CT fusion and FORS technology, have a place and help to reduce patient and operator safety. Thank you very much for your attention.